of the matter is, or the fact of the matter is that morphology is very much the axis of things, and if your morphology is wrong, everything downstream can be erroneous, and at times can send you on a complete wild goose chase. So with that, let's talk to the first students here. Now, each one of these students, I would like to request you to present the slides, the cells which are there at the pointer. So starting with Dr. Kajol.
Good evening, sir. The first cell, the first image that we can see, it is
yes, the one on the upper left corner. If I can set in a pointer here, and let's make it easier. This cell. Now, is the red pointer available? Is visible?
Yes, sir.
Wonderful. So what cell do you think this is?
So this looks like a blast cell with the increased nucleus to cytoplasmic ratio. It's a large cell, and the chromatin is an open chromatin.
All right. So what about the second student? This was Kajal. Let's see Dr. Nandita. I can see Dr. Nandita here.
Yes, sir.
What do you think of this cell here?
So this is also a large cell with raised nucleocytoplasmic ratio, and so the chromatin pattern is diffuse, and there are also many nucleoli inside the nucleolus. This is also blast.
And what about this cell?
So this cell also has raised nucleocytoplasmic ratio, and diffuse chromatin.
So what I wanted to say was that at times the first thing that one should do is learn how to distinguish a blast from what is a lymphocyte. So this is a blast. This actually is a mature lymphocyte. Okay. So if you were to say on the lineage of these blasts, can you say what lineage these blasts are? You know what is lineage, right? You look at a cell and you say that this is this lineage or this is this lineage. So what blast do you think this is?
Myeloblast.
Okay, myeloblast. Someone said myeloblast. And this cell?
Lymphoid blast.
It's a lymphoid blast. Okay, so let's ask the next question to Prayas. Prayas, what do you think this cell is?
Here we can see a large cell with a high NH2C ratio, fine chromatin.
Okay.
Basically,
nucleoli?
Yes, sir. Nucleoli also. 2 to 3 present. Basophilic cytoplasm, and no granules are seen in the cytoplasm.
All right. So let's ask. Yeah, it looks like a what blast? Myeloid cell. And so whom haven't we asked anything to Mihira? Mihira, what do you think this cell is?
So this is also a blast. This has a nice basophilic cytoplasm with granules in it, and I'm not able to see nucleoli.
What do you think this is?
It has an indented nucleus.
So this is clearly a nucleolus, all right? You see a nice big hole in it, and that's the nucleolus, isn't it? Okay. So now what do you think this cell is? What do you think this cell is? What do you think this cell is? So let's go to the next student.
So this is a large cell having increased nucleocytoplasmic ratio and smooth nuclear contour and fine chromatin with basophilic cytoplasm, likely to be of the promyelocyte.
So are we talking about the first cell, the second cell, or the third cell? The rightmost cell or the leftmost cell?
The rightmost cell, I think this is a myelocyte.
This is a myelocyte. Okay. And the middle cell?
This is a blast, since the cytoplasm is very scant.
And what about the leftmost cell?
This is also a myelocyte.
Myelocyte. Okay. And what about this cell?
So this is a blast. We can see prominent nucleoli and OR rod in the cytoplasm, rod-like structure in the cytoplasm.
Let me ask you a question. If this OR rod-like structure or rod is not there, why is this cell different from this cell?
We can appreciate a prominent nucleoli in the cell in the inset.
I can appreciate 2 nucleoli, in fact 3 in this.
It depends on size.
They're both large in size. They're both got abundant cytoplasm.
The cytoplasm is basophilic, and in the cell,
okay. So cells actually don't read the books that we read. They are not rigidly divided into boundaries like myeloblast, promyelocyte, and so on. This is a continuous spectrum of division of development that goes on inside of the human body. All of these can be seen in normal people as well, especially when the marrow is insulted. That means you have infection or the marrow is rapidly dividing. You can see an entire spectrum of these cells, and these are not divided into rigid boundaries. So you must realize that this particular type of cell here, these two, are more likely to be lymphoid because the chromatin in here is bland. When I say chromatin, it is either open or closed. All right. So this is fine. This is coarse, relatively coarser chromatin as opposed to this, which is more open, or which is like this, which is more open chromatin with prominent nucleoli. So these are typically seen in myeloid blasts. Now you must remember that these myeloid blasts that are there, especially which are these kind, in which you cannot appreciate granules but have prominent nucleoli. these kind of blasts are very indistinguishable from that seen in a particular type of ALL, which used to be called in good old days like ALL-L2. Okay, so ALL-L2 and AML-M1 blasts are very indistinguishable from each other. They look the same, and based on morphology, it is very difficult to distinguish between the two. So let's go to the next slide. Okay, so now if you can see these blasts do not have, this particular blast has a higher has a lower nucleocytoplasmic ratio. That it simply means that the cytoplasm is abundant in these cells. They don't have a lot of granules, but the nucleolus is prominent, and these cells are also kind of myeloblasts, but they are shortly before they start differentiating towards your promyelocytes. So cells like this, what you see here, these cells have got prominent nucleoli, but their nucleus is now indented. And you have this pale discoloration here, which is known as a paranuclear Hoff, and these are actually promyelocytes. But cells before that stage, as you can see here, these are cells which are myeloid blasts, which are committed to myeloid lineage, but have yet to become promyelocytes. A fine example of this can be seen in this particular image here. You see this blast, it has got lots of cytoplasm. There is no indentation, there is no paranuclear Hoff, there are nucleoli and granular cytoplasm. So these are type 3 blasts, and type 3 blasts are often can be confused with promyelocytes, but these are myeloblasts. Okay. Now, if you see this, what would everybody agree? What kind of cell this is? This is a promyelocyte. All right. Now, the key to remember here is that this is a normal promyelocyte. Now, what cell is this? So I haven't asked a question to one person. I've had 5 speakers. So who's the person who hasn't spoken yet? Sneka, is that you? Yes, Sneka. So what do you think these cells are?
Sir, I think this is a neoplastic promyelocyte.
Very good. So the key here to note is these are abnormal promyelocytes. All right. So it is very important to recognize abnormal promyelocytes and distinguish them from normal promyelocytes. So if you see lots of promyelocytes in the bone marrow, it does not mean it is acute promyelocytic leukemia. If the cells look like this and of varying morphology of acute promyelocytes, as we will see in the slides below, it is then important to call it as acute promyelocytic leukemia. All right. So what do you think of these cells? Let's go to Mihira. Mihira, can you describe these cells? What do you feel these are?
It's a large cells with round nucleus, prominent nucleoli, and there are cytoplasmic vacuolations.
Okay. Would you like to describe the cytoplasm a bit more? What do you think is the color of the cytoplasm?
Basophilic and no granules.
No, forget about technical terminologies. If I were to ask it to you as a non-medical, what color would you say it is? Pick a color. Blue. Are you sure it's blue? If not blue, what other color could it be? Yes, I heard someone whispering that. That's
Grayish.
Gray. So the argument here is that these cells have a cytoplasm that's either blue or gray. So cells that have a blue-gray cytoplasm typically are monocytes, all right? Monocytic lineage. So these are monocytic lineage blasts, and these are called as monoblasts. Now you see these cells, their nuclear chromatin is very it's pale as compared to a myeloblast. All right, some would say lace-like or whatever, but it's pale with abundant cytoplasm, which is largely devoid of granules, and there are vacuoles, as someone rightly said. Now, what do you think these cells are?
Promonocytes.
Monocytes.
Why would you say they are promonocytes? What argument would you have?
Sir, slightly indented nuclei.
So the nuclei in these cells, is either reniform. When you have heard of the term reniform, what does a reniform mean?
Kidney shaped.
Kidney shaped. So these are typical reniform cells that you see here, but the nuclear pattern or nuclear chromatin is very fine. All right, lace-like as it has been described. And sometimes these nuclei have folds like that of the brain. If I were to draw a cartoon image of the brain, it would look like this. So a brain or even cauliflower. So this is how these brain-like or cauliflower-like nuclei look like. And they again have a blue-gray cytoplasm, but they also seem to have some dark red granules inside them. And these are promonocytes. Once again, because it's a slide seminar, you can say this with confidence, but in real life, if you are faced with these cells, it is often difficult to distinguish from what is a blast to what is a promonocyte to what is a mature monocyte to what is a developing or immature monocyte. So it's not always that easy, but this is a good image to remember. So what are the types of blasts? There are 3 types of blasts. One is type 1 blast, one is type 2 blast, and one is type 3 blast. Type 1 blasts do not have any granules, right? They have diffuse chromatin, high NC ratio, usually have prominent nucleoli. Type 2 blasts have more abundant cytoplasm. They can have a much lower NC ratio. The cytoplasm is abundant, but still may have very few granules, okay? And they can show occasional OR rods in them. And type 3 blasts have many more azurophilic granules, but still not prominent indentation, not prominent paranuclear Hoff. So this is like going to become a promyelocyte, this particular cell. Once again, it is at times difficult to make this distinction with confidence because we are reading the books. These cells are in a continuum of division, always. And monocytes, as I said, voluminous cytoplasm, dispersed chromatin, irregular margin, nucleoli, and most importantly, they are MPO negative and they are positive for non-specific esterase. So this is a wonderful article which you can refer to of all the different types of monocytic lineage cells and how to distinguish one from the other. The key about promonocytes is they are convoluted or indented as opposed to monoblasts, which we saw, which are round or oval in shape. Okay. And they can have some azurophilic granules, whereas monoblasts, exactly like we saw, have very, very rare. That means azurophilic granules are not there. So they are something that is known as blast equivalents. If you see a promonocyte, it is equivalent to seeing a blast. So you needn't count 20% blast. If you have 10% promonocytes and 10% blast, it still becomes that of an AML. So as we discussed, abnormal promyelocytes are also blast equivalents, all right? So they are intensely positive for MPO. What we also see in the bone marrow are also a spectrum of erythroid cells, which are either pro-normoblasts or basophilic normoblasts, or polychromatic normoblasts or orthochromatic normoblasts. I personally find it very difficult to remember one name from the other. I just remember them as intermediate, late, and early erythroid precursors, and that works for me. I find these names very confusing. Okay, but it is important to note the morphology of these cells. What's a blast? What is a promyelocyte? What is a myelocyte? And so on. How do I know or learn about these? You can see normal bone marrows or bone marrows for ITP, which will have all of these cell lineages. You can also look at patients of chronic myeloid leukemia, in which you'll get the entire spectrum of myeloid cells if you want to find out how to do a differential count and find out what these myeloid cells look like. Okay, so normal inhabitants of the bone marrow are also megakaryocytes. You can have young or immature megakaryocytes and mast cells like these and basophils like this. We are not going to go into this. An important thing to remember is these cells. Now, what are these cells? Anybody? Let's ask someone who's not spoken much. Sneha, what do you think these cells are?
Sir, these cells appear blastoid, large cells with increased nucleocytoplasmic ratio. The nucleus has a fine chromatin and with indistinct nucleoli. There's a thin rim of pale blue cytoplasm, more like a lymphoblast.
So you're right, and this point that I've written all this about hematogones also makes it easier. But the point to note here is that these are identical to lymphoblasts, especially ALL, L1 cells, all right? And no one can distinguish one from the other. The key to remember this, why this is not ALL, is that these cells, whenever they are there, they are a sign of a regenerating bone marrow. So they will always be there in the background of normal developing myeloid cells, whereas ALL will typically wipe out the rest of the bone marrow. All right. So hematogones, these are B cell precursors or hematogones, which are there or the component of normal bone marrow. If you look at children, the number of hematogones is really very high, and you should be a little bit careful for making it acute leukemia, because we see 6 or 7 cases every year where somebody has called a normal bone marrow of an infant as acute leukemia, whereas it is not. You just need to be aware of these hematogones. So you can have lots of other cells like plasma cells and osteoblasts and other macrophages and so on. So let's go on to the case discussion. The first case is a 15-year-old male with leukocytosis. So who was going to be the first case?
Me.
All right, so Dr. Nandita, go on.
So case 1, 15-year-old male with leukocytosis. In this male, we can see cells with raised nucleocytoplasmic ratio.
What does that mean, raised nucleocytoplasmic ratio? Is this as compared to what? Is the cytoplasm lots or is it scant?
So the nuclear size is more as compared to the normal ratio.
So hang on there, Nandita. If I were to say that these cells actually have an abundant cytoplasm as compared to a myeloblast, wouldn't you say that the cytoplasm is abundant here?
Yes, sir.
Okay, all right, fair enough. Go on.
The cells show leomorphic nuclei. The nuclei are indented.
Leomorphic? Did you say leomorphic nuclei?
Different shapes of nuclei.
And what word did you say to describe it?
Pleomorphic.
Pleomorphic. All right. So there are, okay. So the nuclei are pleomorphic. Do you think they are regular or irregular shaped nuclei?
So irregular. Some are indented. Some have convolutions, and some are lobed.
Okay, they are lobed and irregular nuclei. And do you think they have? Let's go on to the next slide. Do you think they have nucleoli?
Yes, so they have nucleoli.
They have prominent nucleoli, right? And is the cytoplasm blue-gray or is it granular or what?
Sir, the cytoplasm is bluish. It is granular in one cell.
The cytoplasm does have bluish-gray cytoplasm with some granules, all right?
Yes, sir.
Okay, so what do you think of these cells now? These particular nuclei, they are what kind? What do they remind you of? What cells do they remind you of?
Sir, abnormal promyelocytes, bilobed nuclei.
Abnormal promyelocytes. And do you think that it is okay for these cells to have such this degree of granularity in the cytoplasm, or something's off about that?
Sir, there is less granularity as compared to normal promyelocyte.
What stain is this? This is myeloperoxidase. So what do you think here?
Sir, the myeloperoxidase is positive, showing positive reaction.
Okay. So Dr. Fahima said, or someone said that she can't appreciate the granules inside the cells. You're right. The granules in these are actually inconspicuous. Some of these cells, like what you see here, you can see that there are some amount of granules, but it's largely not very granular. So the diagnosis in this case is that of hypogranular AML. All right. So hypogranular APML, acute promyelocytic leukemia. So these are the flow plots of that case, and you can see that these cells are HLA-DR negative. They are positive for CD13, but they are dim to negative for CD34. They are also dim for CD15 or dim to negative for CD15. They express CD33, and part of them express CD2. Now, this particular phenotype that you see is very characteristic of acute promyelocytic leukemia, especially microgranular variant, and especially that is associated with a particular isoform of BCR-ABL. So what are the differential diagnoses here?
Sir, for this form, the first differential diagnosis will be acute myelomonocytic leukemia. But it is ruled out from the cytochemistry. All the cells are showing positive myeloperoxidase.
So perfect. So the differential diagnosis of such a case should be a monocytic leukemia, but the morphology is really classic. But the problem is there are no granules. If you don't have access to an MPO stain, you will be in trouble because you really can make a confident diagnosis once you see the MPO. So what investigations should be done for such a case?
So first we will do the cytogenetics, the karyotyping. Sir, and then we can also do fluorescent in situ hybridization. Sir, polymerase chain reaction, transcriptase polymerase chain reaction for translocation 15-17.
Okay. So whenever you get a new APL-like diagnosis, there are some investigations which are routine and some investigations which are specialized genetic tests. Okay. So the specialized genetic test is exactly what you said. You first send for a PCR as well as a FISH. It's not an option to send this or that. You need to send both those investigations. But in addition to this, do you think these patients have any other problems?
Yes, sir. So these patients can go into disseminated intravascular coagulation. So we have to do tests for coagulopathies. We have to look for any coagulopathy.
Whenever you have a suspicion of APML, the first thing that a treating physician will do is, in addition to a morphology and MPO, he will ask for PT, APTT, INR, fibrinogen, D-dimer, and platelet counts, because he wants to make sure the patients don't go into DIC, and they need to be supported with a very, very special coagulation protocol wherein you want to prevent DIC-like picture or a massive bleed, because these patients can suddenly, within first few days of diagnosis, they can have an intracranial bleed. And so what is the importance of this diagnosis?
The importance is that we can prevent the patients from going into DIC. We have a treatment for acute promyelocytic leukemia, and that is all transretinoic acid or arsenic trioxide.
So you're right. So this is a very unique type of AML which can be treated with either ATRA or arsenic trioxide. And in today's time and age, you can give even oral arsenic trioxide. So this is a PCR for this patient who can see that this is negative for BCR1 and 2, and this is positive, as you can see by this RT-PCR for BCR3 breakpoint. So this is acute promyelocytic leukemia. All right. And as we discussed that there are a whole lot of treatments available. In the 1950s, this was one of the most dangerous cancers to have, and it was associated with hemorrhagic syndrome or DIC, and patients used to be treated with 7+3, and they did very badly. But today, we started using ATRA in the 80s, and following this, there were treatments with ATRA combined with arsenic, and now there are oral arsenic that can be given to these patients, and it's a highly curable type of acute promyelocytic leukemia. So what do we learn from this case is that it is a very typical morphology, and call must be made on morphology. So although you said there are a whole lot of genetic investigations to be done, you should not wait for any of them. If you see a morphology that resembles acute promyelocytic leukemia, you must alert the treating physician that, hey, I think this is an APL and you should take care of this patient specifically and send for rest of the investigations. But do not wait for anything else, because we have had patients who can pass away within few hours of the diagnosis unless they are treated specifically and given coagulation support. All right, so it requires urgent diagnosis, preventive transfusion support, and even though you may make a mistake, you may call some AML as APML, it doesn't matter. It is okay to overcall this diagnosis. Okay, so the next case, who's going to talk about the next case?
Me.
All right, so 45-year-old male with fatigue found to have petechiae, leukocytosis, and blasts in the peripheral blood. So go on. What do we see here?
So in this peripheral blood smear, we see large amount of myeloid lineage cells, most probably.
Well, at this point, you can just see that there is leukocytosis. The count is high. I can't see anything. Okay, but at higher power, what do you see?
See myeloid lineage, most probably myelocytes. Sir,
most probably
promyelocytes.
Okay.
Sir, N/C ratio is high here. Nuclear contour is smooth, and we see 3 nucleoli, and cytoplasm is basophilic. And in some cells, we can see azurophilic granules.
So as compared to some of the older typical cases that we saw, what do you think of these granules? Are they prominent, or are these granules very faint?
Faint.
So these are very inconspicuous, finely granulated cells, all right? And their nuclei are regular. There is no folding in these nuclei at all, but they do appear to have some prominent nucleoli in them that you can see. Now, if you see the next particular case here, you can see that these cells, especially this cell, has this. Now, what is this?
OR rods.
1 OR rod, 2 OR rod, 3 OR rod.
Multiple OR rods.
Multiple OR rods. Is there a specific terminology that we use?
Phagot.
These are phagot cells. And what about this neutrophil? Is this normal? Anybody wants to comment on the neutrophil?
Sir, it is showing some toxic vacuoles in the
Toxic
cytoplasm.
vacuoles, all right. So I wouldn't go that far. I would say that this is a Yeah, it's just looking abnormal. It's kind of dysplastic. I would even say that the granules in them are less as compared to this. All right, but the important thing to note here is these cells. They are small in size. They are not as big as normal promyelocytes, and these nuclei are regular. So as compared to the previous case, these are regular nuclei with multiple fine granules in the cytoplasm. So what is the differential diagnosis here? Go on, Prayas.
Sir, acute promyelocytic leukemia of microgranular variant.
Microgranular variant. All right. Is that the only DD here?
Also, sir, acute myelocytic leukemia.
Acute?
M5. Myelocytic leukemia.
Acute myelocytic leukemia. What is that?
Sorry, sir. Acute monocytic
leukemia. Okay.
AML-M5.
So it is not a monocytic leukemia. There actually is no DD for this. This is an APML only. All right. The morphology of this case, however, is very unique. Monocytic leukemia cells, as we saw previously, will have a gray cytoplasm which is there. All right. So again, the importance of this diagnosis is making an immediate diagnosis. So this is now fish for PML RARA. Would you like to comment on it?
Sir, there is a green signal which is for RARA gene and red signal PML gene, and here you can see the fusion of red and green signal, which that there is a fusion of PML RARA gene.
So let me tell you that there is no fusion in this. No, there is no fusion in this at all. All right, this is negative for PML RARA. So if there is a fusion that takes place, these are actually 3D structures. Okay, so it looks like there are fusions, but there are actually no fusions. So if there is a fusion, the color will change to a yellow signal, okay, which we are not seeing. So this is a non-rearranged PML RARA. Okay, so as you can see here in this PCR, the PML RARA for this particular case here is negative. You are seeing no band, but for this, you are seeing that the BCR1, BCR3 is positive. So this is actually not PML RARA. Now, what is this?
Positive.
No, what's positive? What is happening?
Fusion is going.
So this is ulta. Okay, this is now a break apart probe. In a break apart probe, what we see here is that this is the normal person's RARA. There is no PML we are looking at here. In a normal person, this will be the signals will be fused. But if the RARA gene is rearranged, they will be separated apart. So it shows that the RARA gene is rearranged and the fish signal is broken apart. Okay. So can you tell me what is happening? Why this is taking place? Go on, I'm waiting for you.
Sorry, sir.
Sorry? Oh, you don't know? Okay, anybody else wants to say? What do you think is happening? Why RARA is broken apart, but PML RARA is negative? Any explanations that you may want to have?
Might show the variant translocation of RARA gene. They are fusion partners for RARA gene that which can be show positivity by using break apart probes.
So for patients that are negative for PML RARA, you also want to look at other variant translocations, all right? So variant translocations in the RARA gene occur, and these are either PML or PLZF or NTM RARA, NUMA RARA, STAT5 RARA. 98% of APL translocations are because of PML RARA, but these rest of these cases also occur. Now, this particular patient, when we used to do this previously, we used to look for PLZF RARA and STAT5B RARA, which were rather common fusions, and we used to perform our real-time PCR to look for these fusions. So this particular patient actually is positive for PLZF RARA, all right? This is a PCR amplification plot, which shows that this patient is positive for PLZF RARA. So why am I describing this? Let's talk a little bit about PLZF RARA. PLZF RARA takes place as a result of translocation 1117. It is rare and accounts for 0.8% of APLs. It has a different morphology as compared to standard APL. The case that I described, if you see the granules, they were extremely fine. Okay, and this is a very typical case which has extremely fine granules. They have these cells which are known as Pelger-like cells. Those cells that you saw are known as Pelger-like cells. They can have thin or rods, and they can be CD56 positive. Why should you know about this? Because this particular type of APML does not respond to ATRA or arsenic-based therapy. It will respond only to AML-like treatment, and it is a bad case of the bad disease to have. So a little bit about OR rods. OR rods were described by in 1903 by an American physiologist from Johns Hopkins called John Orr, who described this in a patient who came to him with a tonsillar mass and elevated blood counts. And what he saw was these particular rod-like projections. He didn't even stain it. He performed a wet smear and looked at it, and he saw these particular structures that were there. But later, electron microscopy was performed, which showed that they are cytoplasmic granules, which are fused. That their structure is similar to cytoplasmic granules. That means they are composed of lysosomes, which are fused. The faggot is used in archaic English to refer to a bundle or unit, most commonly wood sticks. It is also used in description of lepra bacilli inside leprosy smears, as far as I remember this from my pathology days, right? But this is just a little bit of history on OR rods. By the way, there's a fantastic article written by some colleagues of ours from PGI Chandigarh, I think Prashant Sharma and one more, Tushar Sehgal, in European Journal of Hematology on the history of OR rods, and you may want to look it up. Okay, so another patient is now 14-year-old male who comes to you with leukocytosis and thrombocytopenia. You're seeing elevated blood counts, and you're seeing this. Now, how are these cells different? Who saw this patient case? Can you go on describing 2A as well?
Sir, in this In this smear, we can see cells who N is to C ratio is high, and nuclear contour is smooth. And in cytoplasm, we see multiple azurophilic granules, and in nucleus, we see 2 to 3 nucleoli.
Similar to that case, this case
Yes,
too has a similar structure. The nuclei is round, it is not cleaved or indented, and it has, but on the other hand, as compared to that case, it has coarse granules. Okay?
Coarse
This is also a type of PLZF RARA fusion. You can contrast the cells in left to the right. These have fine granules, and these have very coarse granules. Both are characteristics that are described for acute trauma for PLZF RARA. Now, there is this really fascinating article in Blood. If you are interested in the morphology of APML, you should look at this, wherein this gentleman has made a classification system for all the different types of promyelocytic leukemias that are for abnormal promyelocytes. He says that these nuclei are either regular, that means they are round, or they are irregular or apple core or these buttock shaped cells. So if they are nuclear or regular, they can either be hypergranular or hypogranular. And he has described various grades, like either they are hypogranular with no OR rods, with one OR rods, or many OR rods. Hypogranular with no OR rods, one OR rod, or many OR rods. Similarly, he also says that you can have irregular nuclei, which are irregular, which are hypergranular with some OR rod and many OR rods, or hypergranular with or hypogranular with irregular nuclei, one OR rod or many OR rods, right? So the third thing that he describes is that they can have Shidak, Higashi-like blotchy granules, basophilic granules, or Polgar-like cells. So what is the take-home message from this case? Number one, do not by heart this silly classification, but you have to recognize that variations in acute promyelocytic leukemia occur, and it is really important to recognize these variations because these patients are really sick and they can lose their lives within hours unless you alert them for these problems. You must be wary of any case which has granular cytoplasm and intense MPO staining. Okay, and do not confuse reactive conditions for APL. If you are doing a marrow for sepsis or something, you will see a very angry marrow with lots of promyelocytes. But the key to remember is that in an APL marrow, all cells are abnormal promyelocytes. There is not normal cells moving around in the background and so on. APL at times, especially if you are the first person to see this case where you don't have the bone marrow and present with pancytopenia in the smear, you have to be aware and you have to search the edges of the smear. Make a habit whenever you're seeing morphology to search the edges as well as the head end of the smear when you are looking or scanning for abnormal cells. Otherwise, you might miss these cases. Okay, so the third case, who's going to speak on this?
This is the case of 5-year-old girl with leukemia. The bone marrow
bone marrow.
shows. The bone marrow smears are hypercellular, demonstrating the high leukocyte count and predominantly comprising of granulocytic lineage and replacing the other.
So now that we have seen the classification, can you can you now say what kind of cells these are? Are these nuclei regular or irregular?
So the nuclei are lobated.
So they are irregular nuclei. Okay, they are lobated or irregular. Then are is the cytoplasm hypergranular or hypogranular?
Hypergranular, sir.
Hypergranular. And do you think that there are OR rods here? Can we appreciate any OR rods?
No, sir. I can't appreciate the OR rods.
I also can't appreciate any OR rods. Okay. So what is it that we are seeing here? Is that you are seeing these? I can't see any OR rods. And the MPO staining is?
It's positive, intense positive for
intensely positive. Okay. So there is intense positivity for MPO. And can you describe the flow cytometry of these cells?
So the flow plot, in this flow plot, CD45 is heterogeneous and CD33 is positive and CD34 is negative. While CD15 is positive, CD11B is negative, CD34 and HLA-DR both are negative, and CD13 is bright positive.
Okay. So in an acute perfect. So in an acute promyelocytic leukemia, it is important to know that as compared to these black structures here, which are lymphocytes, you can see that these cells have tremendous high amount of autofluorescence. All right, so these cells will seem positive for everything unless you're aware that this is autofluorescence. They have very high side scatter, as you can see. See, this is lymphocytes, but these have granulocytic level side scatter. Now, the thing to remember about abnormal promyelocytes is that normal promyelocytes have bright CD15, but their 15 is dim or it is dim to negative. So this is how you must remember this, and they are negative for HLA-DR and CD34. So for this patient, what do you think is the differential diagnosis?
First diagnosis will be acute promyelocytic leukemia, hypergranular variant.
Yes, so this is acute promyelocytic leukemia. There actually is no DD for this patient, all right? What investigations do you think should be done?
Cytogenetics, FISH, and RT-PCR.
Okay, so I did cytogenetics. This is courtesy of Dr. Dhanlakshmi Shetty. Can you describe this?
This is an interface FISH, which is using a dual color fusion probe, showing separate green and separate red signal. There is no fusion signal. That is no yellow signal.
There is no fusion. So there is no, this is not PML. All right. So what is this? This is a PCR. And can you interpret this transcript identification PCR? PC means positive control.
So this is negative for PML RARA.
Okay, so this is positive control showing that the assay has worked, but this particular case is negative for either BCR1 or BCR2 or 3 transcript. Now, this is the fish using ARARA break apart tool. What do you think is going on?
So the above two cells are showing yellow signals, that is the fusion signal, which is a normal for normal gene, while the below two cells are showing separate red signals. That means that there is a splitting
Actually,
of...
it just looks like that. They are all showing that it is a fuse signal. See, this is also yellow and this is also yellow. This one. So
Okay,
it just looks like that.
no,
Yeah. So there is no
split
RARA
signal.
break apart.
Yes, sir.
Right. So now, what is your diagnosis and what will you do? Boli.
So for considering APML, RARA should be positive. So
now, this is a tough case, isn't it? What do you do when RARA gene is not rearranged? Would you like to look at the morphology of this case and do you think your diagnosis would change?
so seeing the granulation, such a hypergranulation is seen in case of APML only.
Correct. So would you like to change your diagnosis or would you say that I'm sticking to what I'm doing?
I would like to stick to my diagnosis.
Very good, very good. So that is very important to stick to your diagnosis. So we did RNA sequencing for this patient, okay? And I'm not going to get into the details of this, but the point is that RNA sequencing, you can shear cDNA and you attach one particular structure here, which allows for universal PCR. That means you attach an artificial structure based on which you can attach a handle for PCR. And from the other side, you can do PCR with a with a particular gene. So you can actually sequence an entire set of myeloid genes, like 50 or 30 or 40 myeloid genes, and you can identify any partner. So for example, if you want to identify any fusion partner for ABL1, you can identify when you do RNA sequencing for this patient. Okay, so we have used this technology for detecting PH like ALL, PDGFR-AB fusions, JAK2 gene rearrangements, KMT2A, and so on. But this particular patient, we found a fusion which is known as a RAR-B fusion. Okay, so this is in a gene just like RARA, you have RAR-B fusion, TBL1XR1 RAR-B. So if you want to know what's going on, there is something that is known as acute promyelocytic leukemia like AML. So there is a series of patients that has been described in leukemia. This is a fantastic paper from a Chinese group. I urge you to look at it on children, where morphologically they thought this is a APL, but they could not identify anything. So they found 18 patients of APL without RARA gene rearrangements. Without RARA gene rearrangements, but had some other gene rearrangements. Importantly, nearly 33% of those patients did not respond to ATRA-induced treatment. So clearly, this is a problem. Now, those fusions included genes like NPM1, like RAR-A, RAR-B, RAR-G, and so on. And these were actually called as APL-like disease. Okay, but what message should we take from a case? As you hit it rightly on the head, if it looks like a duck, if it walks like a duck, if it quacks like a duck, then it is a duck. Okay, it doesn't matter what the genetics is. So I agree with you, and we too felt that this is the diagnosis is that of APL in this case, and we have now seen 3 of these cases which are APL-like disease. Okay, so next case. Who's going to talk about the next case?
Myself.
All right, go on.
The 59-year-old female with EC fatigability, leukocytosis, and chromatocytopenia.
All right, and what do you see there?
So this is a peripheral smear showing increased leukocytes. With in background low, we could not see any platelet.
Okay, now on closer view, what do you see?
Sir, in this, we can see large cells with increased nucleocytoplasmic ratio. The nucleus appears convoluted with fine open chromatin and some 1 to 2 nucleoli and pale blue cytoplasm, more like promonocytes.
Promonocyte. And now?
Sir, and there is some couple-like inclusions noted in the nuclei.
Okay. And the MPO staining is?
Intense positive.
Intense positive. So the important thing to note here, okay, so let's look at the flow cytometry for this. So would you want to read the flow for this case and see what do you think?
So in this case, CD34 is negative, 117 is deemed negative, HLA-DR is negative, CD33 is intermediate, 13 intermediate, and CD11 is
negative. Okay, the brown cells are the tumor cells. They are negative for CD11B. Okay. So the important thing here is that they are negative for CD34, they are negative for HLA-DR, and positive for all myeloid markers. So what is the differential diagnosis here?
Sir, based on morphology, differential diagnosis are acute monocytic leukemia.
No, what is the main diagnosis that you're saying?
Sir, monocytic leukemia.
Monocytic leukemia. All right. So for a monocytic leukemia, do you think that these cells have too much of MPO?
No, sir.
But in monocytic leukemia, is the MPO so strong? So let's take a poll. How many of the other students agree that this is a monocytic leukemia? What other thing do you think this could be?
Acute myelomonocytic leukemia.
Myelomonocytic leukemia. What about the rest? Do they have anything more intelligent or more different to say than this?
And monocytic leukemia with NPM1 mutation.
Okay, monocytic leukemia. Now, okay, so let's not get into the diagnosis. The question here is why monocytic leukemia? So, by definition, monocytic leukemia will never have intense MPO positivity. Okay, the MPO positivity in this particular case is intense. If you told me that I think this could be APL, I would say, okay, looking at the MPO, the intense MPO staining is there. Now, the key thing that you noted here is that these blasts have these cup-like projections, okay? And this is a distinct category altogether of, as you rightly said, it is possibly an NPM1 mutated AML, but does not mean this is monocytic at all. These are not monocytic lineage cells at all, right? So the key thing to note here, is this APL or not? So look at the flow cytometry. It is CD13, 33 positive, 117 positive, but it is negative for 30, 34 and HLA-DR. So the flow cytometry here can trick you into thinking that this is an acute promyelocytic leukemia. But the fact is it is intensely MPO strong and the morphology is very, very unique, okay, of having cup-shaped blasts. So based on that, we don't think that this is an APL. So these cup-shaped blasts are very unique. These cup-shaped blasts are often associated with NPM1 mutations, and they are also seen in patients with FLT3 mutations, okay? So you must not think that this is diagnostic for NPM1. It is very likely this is NPM1 or a FLT3 positive leukemia. And as you rightly said, NPM1 mutated AMLs can also have a monocytic or monoblastic maturation, okay? So monocytic maturation can also be there in NPM1 mutated AML. However, their MPO is often not strong at all. It's very weakly positive, if at all positive. And NPM1 mutated AMLs can present with multi-lineage dysplasia as well. That means you can have this megakaryopoiesis, this myelopoiesis, and it can be an NPM1 mutated AML. It has no bearing on the prognosis. So take-home message from these cases that NPM1 mutated AMLs can have varied morphology, especially cup-shaped blasts. These are often MPO positive if cup-shaped, and they are negative for 34 and HLA-DR, and you should not mistake this for an acute promyelocytic leukemia. So fifth case. Who's going to read the fifth case?
So me.
All right, go on, Mihira. No, Sneha, who's that? Oh,
Kajal.
Kajal. Okay, go on.
So case 5, 34-year-old female with persistent anemia and thrombocytopenia and recurrent transfusions.
Okay.
So, this looks like a bone marrow smear with we can see some adipocytes and bone marrow fragments on the slide.
Okay. And do you think, looking at the smear, can you comment on the cellularity? Is it high? Is it low?
Sir, it looks hypocellular.
Hypo, you said?
Yes, sir.
Okay, so for a 34-year-old, you think this is hypocellular? Okay, so what do you think is the cellularity of this particle? Let's make a guess. No, don't worry about it. Don't worry whether it's right or wrong. Just give it a shot. It doesn't matter.
So there are some fat adipocytes or some fat spaces.
But the cellularity of the particle is estimated in terms of percentages, right?
Yes,
so what do you think is the estimate here?
So around 75 to 80%.
So if it's 80% cellularity, do you really think this is hypocellular?
No, sir.
No, right? It is not hypocellular. This is an hypercellular bone marrow particle. And if you look at this closely, now what can you see? So let us start in a clockwise manner from top left.
So these appear like megakaryocytes. The top left one is a hypolobated megakaryocyte. And, the top right one looks hyperlobated megakaryocyte.
Bottom left one?
Sir, that looks dysplastic, a little dysplastic megakaryocyte.
How is it dysplastic? Dysplastic as in what?
So the single nucleus and the cytoplasm is abundant but frayed.
Okay,
with
so
some
let's go over megakaryocyte morphology. Okay, so these are new. So megakaryocytes divide by a process known as endo-reduplication. As a result of them, their nuclei are knobbly and brain-like and have multiple lobes. Okay, as compared to that, this nucleus is abnormal because it is small, single-lobed, and the megakaryocyte itself is very small. This is a micro megakaryocyte. Now, if you see this megakaryocyte and this, the nuclei are broken apart and connected by a thin strand. Okay, these are dysplastic megakaryocytes, and this, as you said, is a very hyperlobed, dyslobate megakaryocyte. Do you think there are lots of blasts here?
Yes, sir.
So there are lots of blasts. More than 20% is a clear estimate, right? Now,
yes.
What do you think is happening here to this neutrophil?
So the nucleus, the nuclear membrane is irregular. It has indentations and even prominent nucleoli.
Neutrophils that don't have indentations or have irregular nuclei, they all have irregular nuclei and indentations. What's abnormal about it?
So the cytoplasm is lacking granules. And
perfect. So the cytoplasm is really hypogranular. Okay. So this is a dysplastic neutrophil, would you say?
Yes, sir.
Yeah, so it's a dysplastic neutrophil. And now what about the rest of the erythroid cells? What's abnormal about them, these guys?
So there are a lot of orthochromatic normoblasts.
Okay, but so there is nucleocytoplasmic asynchrony. That means although the cytoplasm is hemoglobinized, their nucleus is still in place.
Yes.
Okay, so that is asynchrony of maturation. Secondly, you see this and you see this. These are budding nuclei, which are again an evidence of dyserythropoiesis. And if you see this, these cells are showing a sieve-like chromatin hook. Okay, and this is megaloblastoid erythroid maturation. Okay. Now, what is this again? This cell at the pointer? This one?
Sir, a neutrophil.
Yeah, hypogranular
Hy-
neutrophil. Okay,
hypogran-
almost pseudopelgar USL, but it's not completely because they have different sizes, but almost like a pseudopelgar USL. See this? What cell is this?
Sir, erythroid precursor, normoblast.
Okay, but what do you think is normal or abnormal?
So it can be erythroblast because the nucleus is the cytoplasm is very scant.
Yeah, it is a megaloblastoid erythroid maturation, almost like megaloblastic anemia. See, like chromatin is happening. Okay, now what cell is this?
Sir, at first glance it appears like a plasma cell, but because of the nuclear features, it is again an erythroid precursor.
Very good. And what about this?
So the similar erythroid precursor.
Okay, so thank you for showing this. Actually, these are plasma cells. Okay, so plasma cells can often be is confused with erythroid cells, and you must learn to distinguish one from the other. Okay, their nucleus is very different. This is more mature. You see these coarse blotches? If I were to remove the cytoplasm, these are just like lymphocytes. Plus the cytoplasm, they have eccentric nucleus, a paranuclear half. These are just plasma cells. Eccentric nucleus, a paranuclear pale coloration. These are plasma cells. But it's okay. Everybody makes this mistake once in a while. Not to get too stressed about it. But remember that erythroid cells can look like plasma cells. Now what is this? This is again like a pseudo-Pelgar USL, almost like a uninucleate neutrophil. Okay?
Yes.
So there are more than 40% blasts, and if you look at the flow cytometry, can you quickly go through this?
Okay. So it is positive for CD33, the blast population, as well as CD117, and CD. It is negative for CD64 and positive for CD34. It is positive for CD13 but negative for CD11B, and positive for CD45 and 38 as well.
So now to summarize, what are the summary findings?
So there is
Don't worry about flow cytometry. Just talk about the big picture.
So there was hypogranulated neutrophils we have seen, and we have seen dyserythropoiesis happening in the bone marrow with some megaloblastoid erythroblast, and even dysplastic megakaryocyte cells as well.
So do you think there is dysplasia in many cell lines?
Yes, sir. In all
Yes. So what do you think is the diagnosis?
Sir, it could be myelodysplastic syndrome.
With if this is myelodysplastic syndrome, what do you think is happening here? Just in this particular picture, I think I can count 20 blasts. At least 10, 15. So blasts are more than 20%. So would you like to revise your diagnosis?
Sir, myelodysplasia with AML.
So AML with myelodysplasia related changes, right?
Yes.
The diagnosis is AML with myelodysplasia related changes. Now let's see how to arrive at this diagnosis. So if you see a bone marrow, the first question is, are the blasts more than 20% or the blasts are less than 20%? If the blasts are less than 20% in the blood or bone marrow, diagnosis is straight away AML-MR is not possible. This is myelodysplastic syndrome. If the blasts are more than 20%, next question to ask is, has the patient received chemotherapy or radiation therapy? If the patient has received such treatment, it cannot be AML with myelodysplasia related changes. This becomes therapy-related AML. If the patient has not received such therapy, does he have previous documented MDS or MDS MPN? If yes, the diagnosis still becomes AML with MR. If this is not seen, is there any other recurrent genetic abnormality seen in this patient, especially NPM1 mutation or CEBPA or any other rearrangement? If it is there, this is not AML-MR. If it is not there, is there dysplasia in 50% in 2 or more cell lineages? If yes, this could be AML-MR. If no, if there is no cytogenetic, if there is no dysplasia at all, you look at genetic abnormalities. We will be talking about these in the next lecture. All right, so coming to the last case now, an 18-year-old male with leukocytosis and enlarged lymph nodes. So who's going to see this?
So this is a peripheral smear, RBC normocytic normochromic, and there is leukocytosis with the majority being blasts. These are 2 to 3 times the size, 3 to 4 times the size of small mature lymphocyte, and they have a moderate abundant cytoplasm.
Very good. So let us look at this in closer power. Now, tell me what's happening.
The nucleus is round to indented. Then there are prominent nucleoli. There are no cytoplasmic granules.
I am really at a loss to find these prominent nucleoli. I don't think there are prominent nucleoli. The nucleus is large. The cells are huge in size. So let's go it step by step. What do you think the cell that I'm pointing to is? Okay, myeloid or lymphoid? Let's take it step by step. Myeloid or lymphoid? Myeloid. Okay, so lymphoid is out. So now if it is myeloid, can you describe this in a little bit in detail? Let's start from outside. What do you think the cytoplasm is like?
Blue-gray cytoplasm.
Blue-gray cytoplasm. Okay, are there any granules? I'm not seeing any granules.
No granules.
So no granules, blue-gray cytoplasm. Is the nuclear membrane regular or irregular?
Means
is it straight round or going little bit up and down?
Little indentation. Not
little
indentation.
Indentation is there. So indentation is there here. But if you see that there is some amount of indentation, minimum, there is not much nucleoli and blue-gray cytoplasm, no granules. What do you think this is? So this is a monoblast, right? It's a classic monoblast that we see. Okay. Now what is this fellow? What do you think the shape is? Does it remind you of any
reniform promonocyte?
Yeah. So this is kidney, no? It is a kidney-shaped nucleus. So this is a reniform nucleus, and again same story, blue-gray cytoplasm and so on. So this is a promonocyte. All right. What do you think this is? This reminds you of which organ? Like a brain, no? Like a brain. It looks like a brain, a cut section of a brain. Similarly, this looks like the top view of a brain. So these are all cerebriform. Actually, should not use the word cerebriform, but they are these irregular nuclei, pale chromatin, and abundant cytoplasm. These are all promonocytes. Now, what cell is this?
Very irregular.
Very irregular. No nucleoli at all. Okay. So what cell is this?
Abnormal promonocyte.
This is normal monocyte. All right. So normal monocytes are some of the most difficult cells to identify, and it requires you to become at least 6 months experience to recognize normal monocytes. In our lab, we say that if you are not hematopathologist, till you can confidently identify monocytes. Okay. All right. So again, same thing. Now the thing I wanted to show you see these cells. If I show just these cells, what did these remind you of? See, this irregular nucleus which is folded. What does it remind you of?
Hypogranular promyelocyte.
Very good. So this actually looks like hypogranular APML. And now you see why there is a problem, why this can be mistaken like hypogranular APML. It's okay to be surrounded in a seminar by many people where everybody has looked at the slide. But if you are alone in your practice and you're reporting this smear, or you're on duty as a resident and you're seeing this smear, it can be very terrifying, I assure you. Okay, so again, you have all these kind of curved, indented cells, but you also have these. Now, what are these?
Monoblasts.
These are normal myeloid blasts. There is no monoblast among them. We saw monoblast, abundant cytoplasm and all of that.
Okay.
No, none of that is there. These are normal myeloid blasts. And then there are these. What are these? Once again, what are these? Yes, they are normal monocytes. Okay, so you are getting to be a hematopathologist. Very good. And again, promonocytes. Okay, so monocytes, you have all kinds of monocytes. You have promonocyte-like cells and so on. So this is the flow of that patient. What do you see here? Can you read the flow?
CD4 is negative. HLA-DR is positive.
Okay.
CD7 negative. CD117 is positive. CD33. CD36 is positive. CD33 is also positive.
Okay. And
then CD14. CD14 and CD14 is
is in a subset. Not chota population looks positive. So few dots are positive. So it's in a subset of those cells. And CD11C is positive or variable. Positive. At least most of it is positive. All right. And 13?
13 is positive.
And 64? Do you think 64 is positive? So what's your diagnosis based on this?
Monoblastic, acute monoblastic leukemia.
So I wouldn't say monoblastic, but I would definitely say acute monocytic leukemia. So why? Because monoblastic leukemia has a particular definition. If you see 80% of more of monoblasts, which means that if you see if you see 80% of cells that look like this, okay, or like this, only then you can say monoblastic leukemia. Otherwise, you cannot say monoblastic leukemia. You can just say acute leukemia with monocytic differentiation. It is in fact not even important to diagnose as monoblastic leukemia because the therapy of this really doesn't matter. Okay, what's the differential diagnosis? You rightly pointed out in your description. What's the differential diagnosis?
Monoblastic leukemia or promyelocyte.
So it can be hypogranular APML, right? And how do you assign but we saw MPO, and MPO has to be
intense positive in APL.
In APL. Okay, so how do you assign monocytic lineage? These are the next questions to ask. So let's review what genetics. So I'll talk about this. I'll show you. So differential diagnosis, as you can see here, this is hypogranular APL and this is monocytic leukemia. This can be really confusing at times, especially when you have too many cells like this. Okay, what really helps is MPO. Monoblasts, especially cells like this, are MPO dead negative and they are positive for esterase, whereas acute promyelocytic leukemia are strongly positive for MPOs. Now, how do you say something is monocytic lineage or not? You have to demonstrate one or more of monocytic lineage antigens such as CD11C, 14, 36, 64, or just non-specific esterase positivity is also sufficient. So this particular case had CD36 positive, bright CD64, 11C positive, and 14 negative. So we can confidently say this is acute leukemia of monocytic lineage. So how do you differentiate what is myelomonocytic leukemia from monocytic leukemia? See, if you see this case, no, it has monoblasts, it has monocytes, and it has granulocytes. So there is a rule of 20 which we apply. If you have 20% blast or blast equivalents, if you have mature granulocytes which are more than 20 and monocytic lineage cells more than 20, so mature monocytes more than 20, granulocytes more than 20, or blast equivalents more than 20, it becomes AML-M4. Now, monocytic leukemia, what happens? 80% leukemic cells are monoblasts or promonocytes, out of which 20% must be blast equivalents and 20% less than that are granulocytic cells. If you see 80% are monoblasts, then you can confidently say acute monoblastic leukemia. Once again, not important to diagnose this, not important to diagnose monoblastic leukemia. Criteria are met, other genetic things should not be met, and it should not be post-chemotherapy because those are distinct entities of their own. So with that, I'd like to say thank you and thank all the students for working hard on this. And I would like to hand the mic over to the moderators to ask more questions.
Excellent slide seminar, Dr. Nikhil.
Thank you.
The images and description were really awesome.
Thank
I would just request Dr. Rajiv sir for his comments.
Sir muted or what?
Uh,
Sir is muted. I think
Okay.
so unmuted.
Can we just take one question? There are a couple of questions.
Okay.
Again, a revision of the same. Can we differentiate between hypogranular APML with monocytic leukemia without the flow cytometric findings?
Yes, a simple MPO stain is more than enough to differentiate one from the other. MPO, just cytochemistry, MPO and non-specific esterase. Some places also have dual esterase, wherein you can on just one stain identify what is what.
There is next question. What are the key difference between myeloblasts and lymphoblasts?
So once again, these are things that are limited to books. In a practical point of view, how you would classify leukemia as a hematopathologist is something that is MPO positive or esterase positive, which clearly makes it an APL, which is an M3 or a non-M3, and everything else that requires flow cytometry. So I would think of it like that. There is, although you can go on describing lymphoblasts on morphology, you require flow cytometry for making a diagnosis of ALM. So this must be taken into account, that without flow cytometry, it is not possible to make this distinction.
We had only 2 questions.
I think sir is online, sir. If you can.
Yeah, Nikhil, I'm very happy that I'm particularly about the selection of cases. The case 1 to case 3, you dealt with APL, and the case and case 4, it was cupping, which most of the residents initially, at least in pathology, they call as nucleolus. That may be your experience also. And then there was a case 5, had another flavor that was AML with MDS, and case 6 was a classic monoblastic. And I just want to say a few words about the APL cases. The first case, the hypogranular case, who was describing that? Who was describing the first case, hypogranular?
Me.
Yeah, you are the one who does not have access to flow and molecule, isn't it? Am I right?
Yes, sir.
Yeah, that is the kind of case on which you should practice a lot. Look at the cells from in the proper manner, become familiar, because that is one thing where you should give a diagnosis straight away. As Nikhil said, a morphological diagnosis must be given very, very fast. And that was a very straightforward case. Case 3 also was something which was straightforward, and which you said you were able to diagnose by RNA-seq. Am I right?
Yes, yes,
Yeah.
case 3.
But case 2 was very interesting. You know, the case 2 had rounded nuclei. That is not what you see classically in the APL, which you would like to diagnose on confidently on morphology. So case 2 was that, and the fine granules were like APL. No two opinion on that. And but the nuclei was not, the very rounded blast-like nuclei. So in a case like that, one would certainly advise investigations for APL, although one would not be as sure as in case 1 and case 3. And now the case 2A was very interesting because they are like normal promyelocytes. Okay, am I right?
Yes, sir. They are very, very. This is a tricky case to.
Yeah, I know exactly, and this was learning for me because I've seen a few cases of this kind where I call it AML, but I kept wondering why they are looking like normal promyelocytes, and I advised molecular tests, and I never got the answer. So now, and looking at your workup, now I know that those cases are actually APL. They don't have the morphological features of APL. Please, I hope all of you know that.
Actually, when we see the MPO, it sets you, Ari, this is so bright. What is happening?
Yeah, but MPO will be positive anyway, even if if they are promyelocytes, and you can have promyelocytes like that in cases which are recovering from agranulocytosis and a number of reactive conditions. So you have to be careful, as Nikhil said. So that was that, and the cupping thing. Nikhil, you'll be the only person, all the residents in AIMS who came and did the sign out with me, not a single student ever recognized the cupping. They all call it nucleoli. The only person who gave the correct answer was Tanu. You know Tanu Singhal in pediatrics.
Okay.
She at that time she was in Bombay. She was in Delhi in pediatrics. Okay. She was the only one who said that it looks like an invagination. Nobody else. So and that is a lesson for the students. Don't be so biased. Everything doesn't have to be a nucleolus or a whatever. And the last case was what?
Monocytic.
Yeah. And one more thing, Nikhil, if you had shown one slide in the very beginning of the classification of monocytes, the hematologica 2011,
2006,
right?
Yes.
They are made 4 groups. The main difficulty with monoblastic is to distinguish between the blasts and the promonocytes. And the current recommendation is that if a cell looks somewhat like blast and you're not sure, then you club them with blast. And Nikhil, I think you may have missed it. There is a paper by Catherine Foucault.
Okay, I'm not aware, sir.
No, yeah, just look it up. In 2020, there's a paper by Catherine Foucault in International Journal of Laboratory Hematology. And that is precisely on the subject of lack of concordance among pathologists with respect to blast, promonocytes, and monocytes. And he says very clearly that the best concordance was if you have blast and promonocytes together. And the immature monocyte and the mature monocyte can be in whatever group you like. Then you can have a look at the paper.
Yes, most certainly, and I'll put it in the group as well for anybody.
Yeah. In fact, last year when I was taking this webinar, I had shown that I discussed that paper. That in fact is what should be followed and not that hematological paper. So it was a very good learning experience for all of us, including me, especially the case number 2. What part is 2A? No, 2A also. Yes, 2A. Because it was you diagnosed it by RNA-seq. That was very interesting. Yeah. So I'm sure the students have also enjoyed it, and you have to learn morphology very well, as Nikhil said. And he will explain that even now, you have to know morphology well.
No escaping it, because if that goes wrong, everything goes wrong.
Yeah, that's true. That's all. I don't think anything else, Komal?
Thank you so much, sir, for your valuable comments and inputs. There is one last question. Again, what is the morphological difference between a hypogranular APL cell and monocytic cell?
Or same thing that he has already answered.
Yeah, he's already answered.
Just do MPO. Don't kill yourself.
But you should, if you practice morphology well, normally
Yes, you can pick it up.
Yeah,
Absolutely.
normally there's no confusion.
No confusion. I agree.
Yeah. Normally there's no confusion, and especially for those who do not have this facility. The idea is to do whatever you're doing. Idea is to do well. You don't think what you don't have. Okay. So nothing is easy. Even molecular is also not easy, as Nikhil will say. Will tell you. If, for example, if you have to do an RT-PCR and you're told to put 20 picomole of the primer into a 50 microliter reaction of a tube, you don't understand what they're talking about. Am I right?
Yeah. It's just getting used to it. Different language.
Yeah, I know. Because nowadays the problem is that now kits are available. So because of the kits, the learning is gone.
True.
Because you people don't use kits, isn't it?
No, not for.
So that's why. So these things are not easy, but so all of you have to study more and get into basically lab maths, lab maths basically. Then you can understand molecular biology or the setup much better. What 20 picomole of a primer means in a 50 microliter, for example, or 25 microliter reaction volume, things like that. Okay. Anything to add, Nikhil?
Nice, sir. So thank you for your comment.
It was lovely, really very, very nice.
So there's one more question. How will you differentiate erythroblasts and lymphoblasts?
I mean, there really isn't any confusion here.
No similarity. No similarity. Is there a similarity? I do not know.
No, that's what they look so different.
Yeah.
Thank you, sir. Thank you, Dr. Nikhil, for such a wonderful session. Our next upcoming slides